So let's look at the different complications in the temporal sequence as we discussed before. So let's look at immediate post-intubation. The most common thing or the most catastrophic thing that can happen is post-intubation hypoxemia. Why does this happen? The post-intubation hypoxemia happens probably because you have not adequately pre-oxygenated this patient prior to intubation, or the FiO2 you have set on the machine is probably not enough. Somebody requires 100%, but you just said 40 or 50. Probably yes, that's the reason. And if you have set 100%, you should always check on the machine whether the machine is actually delivering 100% of FiO2. If the connections of the machine to your oxygen supply are not good enough, sometimes the FiO2 which you have set is not delivered through the machine. So the patient could be actually being hypoxemic because of a low FiO2, even though you have set 100%, the machine is delivering 30% or 40%. So you should look at that. When you set a ventilator, I'm sure the previous speakers who spoke about mechanical ventilation have spoken about PEEP and its effect on maintaining oxygenation. So you need to identify what is the correct PEEP for these patients. Those who are set with inappropriately low PEEP will develop hypoxemia. Sometimes in your enthusiasm or in your panic or in your anxiety or the adrenaline surge of intubating these patients, you intubate them and then you push the tube too far in, it goes into the right main bronchus, and then the left lung doesn't get ventilated, and then the patient develops hypoxemia. So this is another reason for immediate post-intubation hypoxemia. The other reason why patients could become hypoxemic is you have been overcautious in setting the tidal volumes. While we're all aware that excessive tidal volumes or too much of tidal volume will damage lungs during mechanical ventilation, that should not stop you from setting the appropriate tidal volume for the patient. Like at least a 4 to 6 mils per kilogram of ideal body weight is what you should be setting. If your calculations have gone wrong and you have set the wrong tidal volumes, obviously there won't be much ventilation and your patient would end up becoming hypoxemic. Hypotension. This is another problem which I'm sure those of you who have initiated mechanical ventilation would have noticed. And soon you give in the drugs for intubating these patients, the patient's blood pressure drops. The reason for this is in 80% of these patients, the cause of hypotension is the hypovolemia. So always a patient who's been given sedatives like benzodiazepines and opioids should be intravascularly full if you want to avoid hypotension. While an elective preoperative patient might tolerate this kind of hypotension, a hypoxemic patient whose oxygen demand is already on the higher side because of tachycardia and the work of breathing would not tolerate a hypovolemia and hypotension too well. The myocardial perfusion would drop drastically and you could have a peri-arrest scenario because of this problem. So hypovolemia should be aggressively being watched for and avoided while you are initiating mechanical ventilation. Drug dosing is something which you need to know. When you read literature, Western literature gives you a particular dose, but some of our patients don't tolerate such high doses of benzodiazepines, propofol, or opioids. So inappropriate dosing of drugs in an already hypovolemic patient who's compromised because of hypoxemia could be a problem that is resulting in hypotension immediate post-intubation. So you need to be watchful of this as well. We talked about PEEP as being inappropriate PEEP. An inappropriately low PEEP can actually cause hypoxemia, but an inappropriately high PEEP can produce hypotension by various factors. The PEEP increases the intrathoracic pressure, which will decrease the venous return, which can reduce the right ventricular forward flow, which ultimately will result in a decreased left ventricular forward flow. But this effect of PEEP is accentuated by hypovolemia. So if you are setting PEEP on a patient who is hypoxemic and your escalation of PEEP is actually causing a fall in blood pressure, first look at the fact that this could be because of hypovolemia. If your intravascular volume is adequately filled, PEEP, inappropriately high PEEP, can produce hypotension by producing a pneumothorax or a barotrauma. So by trauma by pressure. So pneumothorax in these situations is a diagnosis of clinical examination. So you get a patient who doesn't have an air entry, there's no breath sounds heard, and you have just ventilated him. There's a decent chance that you have blown a pneumothorax because either because of your aggressive bag mask ventilating this patient or because of inappropriate ventilatory settings. The other reason why patients develop hypotension is that while low tidal volumes compromise ventilation, high tidal volumes more than what is required, or if you have set the IE ratio inappropriately wrong, you have set too much of time for inspiration and too little of time for expiration. There's a lot of air trapping inside the lungs, too much of hyperinflation, too much of overinflating the lungs, too much of raised intrathoracic pressure, resulting in hypotension. So these are potential problems which can happen, which you should try to be avoiding in these patients. The other problem which most of you who have intubated would have noticed is a change in the cardiac rhythm. Arrhythmias are common after intubation in a sick patient, in a critical ill patient, in a hypoxemic patient, especially in a COVID scenario where we have learned and we have heard and we have seen that these patients can have myocardial involvement. These patients can have a cytokine storm. These patients can have actually coronary insufficiency. So on this background, a hypoxemic patient is at a higher risk of developing a refractory arrhythmia than somebody who has normal oxygen content in the blood. So the causes of arrhythmia immediate post-intubation could be hypoxemia. So avoid this at any cost. Hypotension, the two common problems which we discussed in the previous slides. These are the two most common causes of arrhythmias in patients who have just been intubated for ventilator support. The patients who are hypoxemic, who are hypotensive, usually have an acidosis. Usually it's a metabolic acidosis, but if there has been a carbon dioxide retention, you could have a combination of respiratory and metabolic acidosis. So an acidotic environment is a myocardial depressant. So if somebody is hypoxemic, is hypotensive, is hypercapnic, you can be safely assured that this patient is acidotic as well. So this acidosis causes significant myocardial depression, and the hypotension, which compromises the diastolic phase of coronary blood flow, can produce myocardial ischemia. And the vagal activity that you may trigger during the process of intubation can trigger a bradyarrhythmia or a bradycardia, which will again degenerate into any of the escape rhythms and perpetuated by the metabolic derangements of acidosis, hypoxemia, and hypotension.